Hello, and welcome to the first webinar in our series, Risk Adjustment Essentials. Today we will discuss early year best practices for payers and providers. I'm Michela Saputi, Product Marketing at Cotiviti. Thank you for joining us today. Before we get started, let me share a few housekeeping items. First, you can resize and move the screen that you see, like for example, the slides or the presenter videos to find the view that works best for you. You can submit questions to the speaker by clicking on the Q&A button in the top navigation menu. And we will address them at the end if time allows. You can also use the Contact Us button to send an email and request an additional follow-up after the webinar. At the bottom, you will find resources with links to additional assets relevant to today's discussion. At this time, we do not provide a copy of the slide, but you will receive the on-demand recording within a few days after the webinar. And now with that, let me introduce our speakers. With us today, Amanda Liu, our Director of Product Strategy. With a strong background in advanced analytics and data-driven product strategy, Amanda focusing on optimizing the value of risk adjustment solutions for healthcare organizations, including by strengthening core programs and developing innovative offerings. And with us today, Betty Stamps, our Senior Solution Consultant, focused on supporting customers incorporate technology to solve the complexity of risk adjustment. Betty brings more than 40 years of experience in healthcare to her role. She holds numerous credentials in health information, coding, and clinical documentation integrity, and has a master's degree in healthcare administration. And now I'll turn it over to Betty to kick this off.
Fantastic. Thank you, Michaela. And welcome everyone for joining us today on our inaugural Risk Adjustment Essentials webinar series. So today's event is really going to be talking about the advance notice that was published by CMS at the end of January. We're going to take a high-level view at some of the regulatory trends outlined in the advance notice. We're going to give you our position, Cotiviti's take on what we are reading. And then we're going to take a look at some earlier strategies, looking at it from both the payer and the provider perspective. And then we'll wrap things up with an action plan for the next 30, 90, and 365 days. So let's get started. When we look at the outline of the advance notice as published by CMS, we can see that there is an effective growth rate of 4.97%. But when we actually take a look at some of the details, including things like changes to the star ratings and risk model revision and fee-for-service normalization, coupled with the decrease in sources of diagnoses for risk adjustment purposes, we actually end up with an effective average change in revenue of 0.09%. Now, for the past several years, particularly looking at 2020 through 2024, plans have operated in an environment of reliably seeing 3 to 5% risk score growth. Now, that's allowed the use of chart reviews, HRAs, in-home visits, and other processes to capture risk adjustable diagnoses that CMS has largely accepted. The 2027 proposed advance notice signals CMS is serious in their stated intention to narrow the focus. And plans that have relied on retrospective chart reviews for coding intensity will likely see margin compression and really should be proactively pivoting to a more prospective approach. So let's take a look at some of the details. As noted, CMS is updating the underlying Medicare data that underpins Medicare Advantage. The proposed model continues to use version 28 of the clinical classification, but it's calibrated using more recent underlying original Medicare data. So we're moving from 2018 diagnoses, 2019 expenditures, to 2023 diagnoses and 2024 expenditures. That's going to allow CMS to reflect more current costs associated with various diseases, conditions, and demographic characteristics. The V28 model is simply being recalibrated using the 2023 diagnoses and 24 expenditures. And that reflects a 5-year jump, which really moves us past post-pandemic utilization patterns. We're also looking at excluding diagnoses from audio-only encounters, and also that proposed idea to exclude diagnosis information from unlinked chart review records. Now, we're going to break down in more detail in subsequent slides the things that we're seeing in the advance notice. As noted, with the update to the 2023 diagnosis, 2024 expenditure, that's really going to allow CMS to update the recalibration of constraints across HCCs. They're starting with one specific HCC, CKD stage 3, and they're removing those constraints from stage 3B and stage 3. We also note that they will continue the separate normalization factors for MAPD and standalone PDPs for 2027. And lastly, we know that PACE organizations will continue to transition to EDS submissions and the use of the version 28 model. It's important to note that the unlinked chart record review exclusion does not apply to PACE for calendar year 2027. And if you are a PACE participant, you really want to be monitoring specific model changes as announced in both the advance notice and the final notice. So let's look at these in a little bit more detail. When we think about what is going to happen with the update to the underlying Medicare data, as noted, version 28 is still the model, and we don't see changes to the actual HCC categories themselves, but we are seeing significant revisions to the proposed HCC coefficient value. We start with baseline demographic weights that have a small incremental decrease in their value. And more importantly, we see that there are 70 HCCs with decreased coefficient weights. Now, these are very specific chronic conditions that we're very familiar with, things like morbid obesity, congestive heart failure, COPD, depression. Even some of our active cancer codes will see a decrease in HCC coefficient value if this model is adopted. Now, conversely, we do have increased coefficient value for more acute conditions, things such as pressure ulcers, acute myasthenia gravis, and severe skin burns, again, likely due to that more updated cost expenditure for these conditions. Altogether, we have 50 HCCs that have a proposed increased coefficient value. The second thing that we note is the exclusion of diagnoses from audio-only encounters. Now, this is nothing new. CMS and Medicare Advantage has always disallowed audio-only encounters. However, we did have new modifiers 93 and FQ that were introduced in 2022. Because we are updating this information, they are specifically calling out that those modifiers will be the justification for disallowing audio-only encounters. The last item we want to look at here is the intention to move away from unlinked chart review records. So really, CMS is intending to move away from aggressive retrospective coding practices and really move to a more proactive correlation of the diagnoses to the care delivered. The policy change description provided states that CMS will exclude all diagnosis information from chart review records not associated with a specific beneficiary encounter for risk score calculation. This signals a pretty clear emphasis that CMS is moving to encounter-linked diagnoses. They want diagnoses that are specifically tied to care delivery, not a retrospective review that is completely disconnected from patient care delivery. Now, it's important to note that CMS states plans can still submit unlinked chart review records and diagnoses, but those diagnoses will not count towards risk adjustment payment. This is really a lot about moving away from aggressive coding practices and really correlating those conditions to the care delivered. It's estimated that this is going to have an impact of $7.2 billion in payment reduction. So this is certainly a key proposal in the advance notice. Today, plans really should be considering measuring or quantifying their unlinked chart review exposure. Retrospective chart reviews still continue to provide very valuable information, specifically looking at RADV defense, quality improvement and encounter validation, but we really want to move away from it being the source of the risk adjustable diagnoses capture that occurs throughout the year. What are some of the other trends on the horizon that we're seeing? Well, in February, OIG released a Medicare Advantage industry-specific compliance program guideline. This is an important document, and if you are a Medicare Advantage payer, absolutely you want to make sure that you have this downloaded and are aware of what is in here. CMS is signaling that they are expecting Medicare Advantage programs, payers to adopt effective compliance programs. And this includes things like monitoring and evaluating data accuracy, as well as ensuring that diagnosis codes are driven by face-to-face encounters and acceptable data sources. The other important publication came out at the end of January, which is our RADV audit update. Again, this was a CMS HPMS memo, and this really outlines CMS's plans for RADV audits. We know that there had been a lot of proposals that were caught up in some court cases. CMS is still signaling that they are moving forward with RADV audits. There is an accelerated timeline for the rollout of each year. So we are going to have a 5-month window to comply with record submission, but each of those new audits will start in a 3-month rolling timeline. So there will be overlap in those RADV audits. They also intend to increase the scope to all eligible plans. This was communicated previously. And there are operational updates to the sample size and the submission deadlines. So again, really important that anybody who works with RADV audits is aware of these proposed changes. So we want to know how you're responding to this. We'd like to put this out for a poll right now. How are you responding right now? Have you started using the advance notice as a method for evaluating its analysis? Are you launching changes in anticipation of these shifts? Or are you going to wait for the final notice before you start making any definitive changes in your program? We're going to give you just a couple of minutes here to submit your responses, and then we'll see what the answer is. Okay, we're going to go ahead and see what we've got for responses so far. And it looks like fantastic. We're starting to see a number of organizations that are looking at impact analysis, and could not agree with you more there. While we are waiting for the final notice, you don't want to be caught unaware. And so starting to look at what is in the advance notice proposals and making some kind of proactive modeling changes is certainly an appropriate strategy to go forward with. All right, let's go ahead and move on. And I'm going to turn it over to my co-presenter, Amanda, to give you our take on what we see in the advance notice. Amanda, take it away.
Thank you, Betty. So that's the regulatory backdrop. Now I'd like to step back for a moment and share our interpretation. So not just what CMS has proposed, but what they signal. So how should we be thinking about risk adjustment differently going forward? To do that, it helps to look at how the strategy has evolved over the past few years. All right, this timeline will probably feel familiar to many of you. If we look back at the last several years, say 2020 through 2024, we know many organizations saw meaningful RAF growth through retrospective strategies, chart reviews, HRAs, in-home visit. Under the rules at that time, those approaches really worked. Then the V28 started narrowing that pathway, but a lot of organizations stay on the same retro-heavy playbook. But if the 2027 proposals are finalized, this could mark a really meaningful shift. Encounter-linked capture becomes the expectation. Documentation that isn't tied to a valid encounter may generate diminishing ROI. But that doesn't mean documentation improvement goes away. It means it moves earlier. it shifts towards embedding the documentation improvement inside encounter-based workflow. And organizations that make that shift are positioned well, regardless how the final rule is shaped. And those that remain heavily depend on retro-only lift may actually see ROI compress over time, especially if the chronic conditions coefficients finalize as proposed. And when you layer compliance on that shift, the picture becomes even clearer. So now let's talk about the compliance. Because the compliance environment, is more structured than it was a few years ago. Revy expansion isn't theoretical, it is happening. CMS has stated its intent to ultimately audit all eligible contracts annually. New audit cycles are launching roughly quarterly. Many of you may know this older mindset, so maximize the capture across all possible channels, and then manage the recoupment as part of the cost of doing business. However, this actually becomes harder to sustain in the new environment. OIG recent guidance, while voluntary, really reinforces the shift. Now the emphasis is on clinical supported diagnosis and real internal controls. So not just is there documentation, but does it reflect the clinical reality? There's also explicit emphasis on the board level accountability and compliance officer autonomy. And here our view is simple. Fewer defensible encounter-linked diagnoses will likely outperform a larger volume of unlinked ones. Really, quality of the capture matters more than the volume. So if that is the environment, the next question becomes timing. And speaking of timing, this is one of the most practical implementation of everything we have discussed. Historically, risk adjustment activity has concentrated heavily in Q3 and Q4. Retrospective chart retrieval sprints and then submission deadlines, all the last minute gap closure. Under the proposed framework, that cycle becomes less effective because by Q4, the opportunity to generate new encounter-linked diagnosis for that payment year is largely closed. At that stage, you are mostly validating what has already been captured. If finalized, the 2027 rewards earlier action. So Q1 and Q2 become the most important window for prospective suspect sharing, for provider education and pre-visit planning. And then Q3 shifts towards concurrent monitoring and point of care documentation support. Q4 becomes validation and audit readiness, not discovery. And for providers, this shift creates both a challenge and an opportunity. The challenge is earlier workflow demands, but the opportunity is really meaningful because plans are likely to invest more in provider-facing tools, in data sharing and collaborative analytics to support documentation at the point of care. The economic incentives are increasingly aligned. Plans need encounter-based capture, and providers benefit from clear workflows and stronger documentation quality support. And that alignment creates the foundation for more productive payer and provider partnership. And that actually leads a broader structural shift we are seeing across the industry. So I want to show you what do I mean by that. As the encounter-linked capture becomes central, risk adjustment and quality start converging around the same clinical moment, that is the visit. The logic here is simple. If you bring the patients or the member in, you can update the documentation, close quality gaps, and refresh the care plans all at the same time. the most effective organizations are running this as one integrated strategy. They identify high-risk members, then schedule comprehensive assessments. During those visits, they address documentation accuracy, care gaps, and quality measures simultaneously. And at the same time, member experience matters. A health plan's VP of operations described her biggest challenge to me this way. We have different teams talk to the same members at different times for different programs. To me, it's like having 3 different pizza delivery services show up at the member's house with different toppings when they only ordered 1 pizza. So when your members receive outreaches from 3 different vendors for 3 different reasons, say one for risk gaps, another for quality measures, and third one for annual wellness visit, engagement drops. Consolidation reduces aggression. Integrated workflows reduce fatigue. And from a plan perspective, the provider relationship becomes one of your most important risk adjustment assets. All right, so now let's move from interpretation to action. So to what should you actually be considering and doing right now? In this section, Betty and I will alternate between payers and provider perspectives so we can cover both sides. But before that, we would like to get a quick sense of who we have in the room today. So please help us understand who we have in the audience. What type of organizations do you represent? Are you a provider group? Or are you a payers? Or both, integrated system?
We're certainly seeing a lot more integrated systems where we have value-based contracts and a provider organization working as a delegated entity. So I'm glad to see that we've got all of our options on this slide.
Exactly. That's really true. Thanks for that. Yeah, I will give everyone a couple of more seconds to make the selection. And I think we have, yeah, I do see a lot of results are coming in. I'll just give 3 more seconds. 1, 2, 3, okay. Great.
Oh, that's
okay.
Fantastic distribution. So really happy to see, this mix. It's really terrific.
Yeah, I cannot agree more of that because, early year success is not siloed at all. We like this healthy mix of all the parties. Early year success really requires coordination between all the parties. So as we walk through the strategies today, we will call out what matters most for payers, what matters most for the providers, and where the alignment makes the biggest the difference. So with that, let's dive into our first strategic area. The first priority for payers is establishing your 2027 baseline with defensible encounter-linked data. So we suggest you start by quantifying your unlinked CRR exposure. How much of your risk score is coming from diagnoses that are not encounter-linked today? What revenue could be impacted under the proposal? Which conditions and which member segments carry that exposure? Because this is not a theoretical exercise, it becomes the foundation for your downstream decisions, financial plannings, network engagement, and compliance posture. Once you quantify that exposure, the next step is to align internal stakeholders because your finance team needs to have that clarity on revenue implication. Network engagement needs to consider how provider engagement strategies may evolve, and your compliance team needs to understand how unlinked CRR exposure intersects with risk adjustment REVI risk. So all those conversations worth having now before the final rule is released. And operationally, accelerate claims processing. Early year encounter represent your highest value opportunity. So please make sure claims are captured within EDPS submission window. And lastly, when communicating the proposed methodology changes to your providers, focus on actionable guidance, not just regulatory summaries, because providers, they really need to understand what is changing operationally and what you need from them. With that, I will turn it over to Betty for the provider perspective.
Fantastic. Thanks, Amanda. So one of the things that I want to point out is while we are discussing the advance notice for payment year 2027, this is going to be encounters that occur in 2026. So when we think about provider strategies, this really is the here and now. So first and foremost, all of that information that the health plan is working with is generated from the provider. So starting with making sure that you're capturing all of those conditions at the point of care when they are assessed and documented in the clinical record. Now that might sound easier than it is in reality. We'd have an opportunity here to work collaboratively with your health plans to identify where there may be documentation or claim gaps. So certainly the health plans are in a position to understand where there may be some deficiencies or some gaps that the provider networks can use to put in some improvements in place. Something as simple as ensuring that your rendering provider NPI numbers are accurate and correct, and absolutely data service accuracy on the claim. It is definitely an issue when the data service on the claim does not correspond to the data service in the clinical record. And with more and more EHRs incorporating pre-charting capabilities, it's incredibly important to ensure that you've got data service accuracy across both the clinical record and the claim. And lastly, an opportunity here is to really leverage your EHR template to reduce any post-visit coding gaps. So make sure that whatever templates your clinicians are using are really designed to drive that idea of capturing a condition, the status and assessment of that condition, and the plan of care. Again, CMS has been very clear that they are looking for care delivery. They are not looking for random diagnosis capture, and ensuring that you've got that in the clinical record at the provider level is going to go a long way in ensuring that the health plan has that defensible encounter linked data. Okay, Amanda, what's up for encounter linkage requirements?
Great, thanks for that question. So the next we want to talk about encounter linkage readiness. So for payers, you want to start by understanding how many of your chart review findings today are unlinked to encounter records, and then is to clarify that ownership. Is the linkage managed by your coding team, claims operations, or this is a shared workflow? Because without that clarity, execution will become so fragmented. And from a technical standpoint, implement matching logic based on member ID, rendering provider NPI, and the days of service within an appropriate tolerance window. And then set the confidence threshold. Exact match should auto-link. Partial matches move to manual review, and unmatched records hold pending claim refresh. And then track your linkage rate as a core KPI. For many organizations, achieving over 90% automated linkage for clean matches is a reasonable target. But the key here is measuring and improving continuously. And importantly, create that feedback loop with your providers. Share the reports that show conditions documented in chart but not coded on claims. That feedback becomes the bridge between retrospective findings and prospective workflow improvements. So Betty, what does that look like operationally for providers?
Thanks, Amanda. Well, again, because we know that the information starts with the provider, there are certainly several things that provider organizations can be looking at to ensure that they've got the encounter linkage occurring. We definitely want to be looking at strengthening point of care coding. Now, we know that in many, many provider organizations, it is the clinician who is selecting the diagnosis codes for every patient visit. Make sure that your providers are empowered and understand some of the requirements of coding. We don't expect clinicians to become coders, but we do need them to understand the basics of the code selection that they are doing. Certainly ensuring that the claim submission captures all of the conditions that were assessed during the encounter. In the provider environment, we are challenged with the limitation of only 12 diagnosis code slots on the 837P claim format. And it's not uncommon for annual wellness visits or chronic care visits to actually have more than 12 diagnoses. Work collaboratively with your health plans to understand what their preferred strategy is for submitting those additional diagnosis codes. And make sure that you are, in fact, getting all of those risk adjustable conditions within that limit of diagnoses that are submitted. As mentioned before, NPI and data service integrity is really important, making sure that the rendering and billing provider NPIs are correct and on the claim. And another thing that's really important here is make sure that the information that is on the claim that you drop out of your provider organization is the same information that is received by your clearinghouse, as well as is received by the payer. We do know that there are situations where your EHR may actually be throttling or limiting the number of diagnosis codes that are sent out. There may be situations where your clearinghouse is also making modifications. So making sure that you're actually confirming that claim integrity from your door to the payer's door is a really important process. An opportunity to participate in plan-initiated reconciliation process is invaluable. Use the information from your health plans that identify linkage gap reports to see where you may have workflow issues in the provider organization. And again, we can't reinforce enough how utilizing that EHR template is really going to improve that opportunity to capture the clinical information and ensure that it is coded to the highest specificity. We do know that there is a difference in the lens for risk adjustment diagnosis coding when compared to something like E&M or medical necessity diagnosis coding. Make sure that the coders that are looking at those risk adjustable diagnoses really are focused on what is appropriate for risk adjustment so that you're ensuring that you're capturing all of that important information in the claim that is submitted to the health plan. All right, up next, let's talk about chronic conditions.
Exactly. Let's talk about the conditions, how we prioritize them, because not all HCCs carry the equal impact. We know a relatively small set of high prevalence chronic conditions drives a majority of risk score performance. Under the proposed recalibration, many of those coefficients are projected to compress, as Betty mentioned earlier. That means accurate and complete capture becomes the baseline, not upside. Our recommendation is to distribute member-level suspect list by the end of Q1, stratified by recapture risk. And then focus first on those high prevalence, high impact chronic conditions, things like diabetes with complications, CHF, COPD, CKD, major depression, vascular disease. And then monitor coding velocity by practice so gaps can be identified earlier when there's still time to adjust. and also flag members whose diagnosis pattern may need additional documentation scrutiny. While OIG does not specify particular diagnosis, those conditions frequently identified only through retrospective channels may need additional clinical validation. So Betty, how should providers operationalize that?
Well, I'm glad you asked, Amanda. So let's talk about provider capture strategy for those high impact chronic conditions. We definitely want to encourage all of our providers who are attending today to use structured visits, things such as annual wellness visits, chronic care visits, or even your routine quarterly follow-up visits to capture those chronic conditions. We want to make sure that we are truly understanding the disease burden for those patients. This is a fantastic opportunity to ensure, again, that that annual wellness visit or chronic care visit template is really designed to capture all of the necessary clinical information on the status and plan of care for those diagnoses. This is also a terrific opportunity to put in some type of a pre-visit chart prep or an outpatient CDI program using your internal staff, whether it be your medical assistants, care coordinators, or even a formal outpatient CDI program that uses clinical documentation integrity specialists or risk adjustment coders. Really being able to look through the patient's clinical record and bring those conditions to the attention of the clinician at the time of that annual visit goes so far in making sure that we capture those conditions. For some of our more complex patients, the number of diagnoses that need to be assessed, documented, and coded can be overwhelming for the clinician. And a point of care notification system really just helps ensure visibility to the clinician at the time that they're seeing the patient. You definitely also want to align your coding audits with high-risk conditions and high-value HCCs. So that high-risk OIG list that Amanda referenced, this absolutely plays in on the provider side. We don't expect to see patients with acute MIs or acute CVAs occurring in the office, and it's almost always due to a coding issue, not a clinical condition issue. So make sure that you're identifying any of those opportunities for correcting the coding, and make sure that you're using some of those plan analytics to help identify where there may be gaps or opportunities to improve the coding. All right, Amanda, what's next?
Next, we want to talk about really important topics, reducing the burden. The industry today is increasingly moving towards this hybrid model that balances efficiency, compliance, and also provider experience. One effective approach about reducing the burden is sharing documentation performance analytics with your providers. Peer comparison, when positioned constructively, can be a powerful motivator. And also, this really helps is to evaluate EHR integrated with FHIR-enabled tools that surface the coding opportunities directly within the clinical workflow. The technology exists to deliver suspect conditions at the point of care. Now, the key question is whether those tools are embedded within the workflow or operating externally. Another important lever is consolidating vendor touchpoints. If providers hear from multiple programs independently, we talk about that, right? Risk adjustment, quality, and all the different asks all coming to the providers totally separately, fatigue and disengagement really follow. And finally, measure provider engagement and satisfaction alongside capture rates. In an encounter-centered model, friction undermines the long-term collaboration between providers and payers. Collaboration really drives performance. So Betty, on that note, what should providers be doing proactively?
You know, Amanda, I can't agree with you more on the need for collaboration between the providers and the payers. We really want to be tied together on making sure that the patients are receiving appropriate care. And you do that by ensuring that we understand what the disease burden is. So, hybrid models and workflow integration really are key in the provider world. We definitely want to encourage provider organizations to proactively engage. If you have an opportunity for plan sponsored documentation education, absolutely take advantage of it. This is a fantastic opportunity to supplement your own education, usually with very highly skilled, qualified education specialists. Now, you do want to make sure that the education provided is in alignment with your internal policies and procedures. But again, this is a fantastic way to reinforce to your clinicians the importance of clinical documentation. Using those reports from your health plan to identify improvement areas. Again, if you have the opportunity to understand what diagnosis codes have been removed from CMS reporting due to lack of clinical documentation, it is a wonderful opportunity to ensure that you've got improvement plans in place for that. Using your EHR, absolutely work with your EHR vendor support to ensure that the coding workflows are appropriate. The last thing that you want to hear from your provider is that they didn't capture the diagnoses or it was not clinically specific because the process is too cumbersome, too many clicks, or there is a limit to specificity. Make sure that those provider diagnosis pick lists are not limited to your generic, not otherwise specified codes. We want clinical specificity in coding that correlates to the clinical specificity in the record. And lastly, the last thing that we want to encourage is, again, the idea of a value-based arrangement, a partnership between the provider organization and the payer. This is a win-win for both sides. It's really going to allow you to build a value-based agreement that rewards documentation quality alongside the outcomes. We want that collaboration. We want that sense that the providers and the payers are together in ensuring the patients receive the most appropriate care. And by putting together some type of a value-based arrangement, that really gives everybody an opportunity to be invested in the outcome of the process. All right, Amanda, what's next?
Yes, thanks, Betty. So now next, let's actually close this strategy session with the audit readiness. CMS intent is to ultimately include all the eligible contracts on an annual basis for REDV audit. So accordingly, every contract should be planning as if it may be selected for REVI each year. So first, run internal pre-audit on those high-value HCCs from recent payment years, for example, 2024 through 2026, which are most likely to fall within expanded audit cycle. Also, ensure record retrieval processes can reliably meet the 5 months submission window. 5 months may seem long, but when coordinating across multiple provider systems and potentially large enrollee samples, that window moves quickly. And finally, implement structured deletion workflows for diagnoses that do not hold up on internal review. Proactively correcting those unsupported codes and associated overpayments really aligns directly with both CMS and OIG expectations. And it's also far preferable to having issues identified during REVI audit or investigations. So Betty, what does the audit readiness look like for providers?
Well, of course, plan success is largely dependent upon provider strategies. So first of all, ensuring that you've got complete accessible clinical records for your Medicare Advantage patients. Again, ensuring that that clinical documentation those conditions. we absolutely want to encourage any provider network to respond promptly to record requests from health plans. We know that most provider organizations are participating in more than one Medicare Advantage program, working with more than one health plan. And sometimes these requests for records can feel overwhelming. But this really is an opportunity for you to absolutely display the complete clinical record at its best. So we want to make sure that you are responding promptly to those record requests. And also understand that chart quality is affecting both plan audit exposure and your own reimbursement referral and network standing. So we really want to make sure that everybody understands that audit readiness is equally important for both the provider organization as well as the health plan. So absolutely be ready to go with these record requests when the health plans start submitting them. So with that, we're going to take a look at some things that actually can come up in the next 30 to next 1 year. So let's talk about things that both health plans and provider networks can do. In the next 30 days, we definitely encourage our payers to be looking at the extent of your unlinked chart review exposure. You really need to understand where your diagnoses are coming from. And if you find that many of them are actually being generated by unlinked chart reviews, this is a great opportunity to start rethinking that strategy. On the provider side, we're already into March. So this is a fantastic opportunity for you to start looking at some of those January and February claims to ensure that you've got coding completeness. This is a great opportunity to identify, are things documented in the record but not coded on the claim? Were things coded on a claim that were not supported by the documentation in the clinical record? Really use the first 2 months of the year to kind of understand where your gaps are so that you can put in education and training plans. And then we want both organizations to really look at weekly data review. You really want to understand where you are in your initial score tracking to understand where there are opportunities for making changes. Over the next 3 months, well, we'll have the final notice released, and so we will have definitive action plans that need to be done. From the payer perspective, we want to get those suspect lists shared with providers. Use your prior year claim data to understand where there are diagnoses for recapture opportunities and make sure that you are putting in strategies for prospective or same year gap identification. On the provider side, this is a great opportunity to really focus on that pre-visit chart prep and planning for chronic condition capture, again, whether it be through an annual wellness visit or some other specific visit strategy. And again, using your EHR templates to drive high-value HCC capture is incredibly helpful. Both should be aligned on shared metrics, and this again really reinforces that collaboration perspective. We want to make sure that providers and payers are aligned on what metrics need to be captured. That includes both revenue integrity and clinical outcome measures. And for the rest of the year, up until we're looking at advance notice for payment year 2028, well, from a payer perspective, really making that move from retrospective to more of a prospective or hybrid model. This is something that won't be achieved quickly or easily, and so this really is a long-range goal. From the provider side, looking at longitudinal documentation improvement programs, again, CDI, successful CDI programs in the outpatient environment take time. It takes time to build staff that are comfortable with the entire process. So the sooner you get that launched, the more likely you are to be successful over the next year with it. And looking at those value-based arrangements that reward both quality and coding accuracy, really helpful. We want both payers and providers to be prepared for expanded RADV audits. So really focusing on internal audit programs, again, both from the provider and the payer perspective. This is a fantastic opportunity to really collaborate and identify where you are identifying opportunities for improvement, where there are operational or structural changes that can be made. So hopefully we have given you some good ideas and strategies on what to expect. I'm not sure that we actually have time for any live Q&A, but Michaela, I'm going to turn it back over to you.
Thank you, Betty. Yes, we had a lot of content to cover during today's presentation, and unfortunately, we have no time left to take questions live, but our teams will follow up with you to answer your question, and you're always welcome to reach out to us via email to continue the conversation. Let me take the opportunity for a quick reminder on upcoming opportunities to connect with us. If you're attending RISE National, we hope you'll visit our booth and meet us in person. And don't miss the next appointment in our webinar series, starting in April with a review of the Medicare Advantage Final Rule and best practice to put future-proof compliance. This concludes today's webinar. Please take a moment to answer a brief survey about your experience with us today. Your feedback is very valuable and will help us determine future topics of our webinar. I'd like to thank our speaker, Amanda and Betty, and thank you all for joining us today. We look forward to seeing you again soon.